Thank you for that introduction. I am so excited to be here with you all today to share a bit about the notion of how we can use science and innovation to reduce disparities in adolescent and young women's health. I have several disclosures, though most are related to my research and most are through my institution. So I'd like to start here. It seems an interesting place to start around adolescent health to talk about this notion of young people having good sex. And many years ago, I was at a conference in Malta and heard the current leader of the CDC STD hepatitis tuberculosis branch really talk about this notion of what good sex means for young people. And I walked away from it with this notion of that it must be consensual, that it must be unimpaired, and that it must be safe. And so I've embraced that phenomenon as I've moved forward through my career and in my care delivery for young people in practice. It started also because some of my earlier work demonstrated that young people who had sexual victimization and adverse outcomes early in their development really had also adverse reproductive health outcomes in young adulthood. So we used data from the Baltimore Prevention Project and conducted a cross-sectional analysis of adult data and really showed there were gender differences in sexual victimization before young adulthood, that young women were more likely to report experiencing sexual victimization, that both young women and men reported sexual victimization and were affected by it, and that it was associated with STI diagnoses as well as pregnancy before young adulthood. And this made me think a lot about what it means also in the context of relationships. And so intimate partner violence is also a sexual and reproductive health right. And so what we see, though, is that many US women experience some form of IPV, including psychological aggression, severe physical violence, or rape, and that it directly impacts their sexual and reproductive health and autonomy. And what we see here in this national data is it also affects their outcomes. And so for me, this notion of safety became increasingly important also in terms of what we see and the concerns that young women have as they come into clinic. And then there's also this issue around what happens. So I live and work in an area that has a higher STI prevalence than many other areas in the nation. But what we see is that we also want to do our work as public health professionals around partner notification and partner treatment. But we see that many people fear partner notification and really, particularly when it's associated with a concerning STI. And sometimes they're concerned that the partner will blame them, they'd be accused of cheating, undermining trust in relationship, or that they could be threatened with physical harm. And so there are all these reasons why young people just might not be able to engage in the good work of public health practice in alignment with us. I've also been looking at this sort of notion of how we think about young women, their sexuality, certainly in the United States, but it's certainly an international issue. And, it's interesting, in 2001, Kate Costner really came out around this notion about date rape and in a very public way, really tried to amp up the national debate around what we should do next about it. Yet we're still talking about that in 2014, what this crisis looked like in higher education and how we were going to handle it. And then now in 2020, we see the education secretary really talking about new campus sexual harassment rules, really designed to boost the rights for the accused. And so we see this evolution over time, which for me really suggests that as we think about sexual safety for adolescents, for young adults, for young women, we really have to be thoughtful about what policy looks like and how policy can shape safety. There's also the impact of the Corona-19 pandemic on those relationships. And what we see within the pandemic is another pandemic of intimate partner violence. And reports of digital abuse increased from 101% from 2019 to 2020. And in addition to, what we see are actual reports of physical and other psychological abuse. So one of those issues that we think about again is, is this happening just in the United States, or is it a national issue or international issue? And what we see in earlier in our development around talking about the international issue as well, is that, in 2014, around the same time we began to have our discussion in the United States, if you looked back carefully to that Time magazine cover I showed you from 2014, you saw this as also an issue on the front cover, that almost 300 Nigerian girls were really taken from their communities. And there was a national phenomenon, both here in the United States and an international outcry to bring back our girls. But the reality is that, in 2020, 6 years later, 112 of those girls were still missing. And of those who were found, a significant portion of them, by the time they were found, were either pregnant or parenting, indicating the degree of sexual violence that was experienced by them during their captivity. I think there are also significant health disparities in how we think about missing young people and the sexual issues associated with that. And African-American youth go missing at a higher rate than white young people in the United States, but we don't have the same degree of outrage. We're not looking for them. And so I think that in an area where I live, where you see a larger proportion of African-American families living, this is a real concern, particularly alongst the I-95 corridor. The other reality is that at the same time as there are these risks out there posed by the adult world, and many times, the proportion of young people who engage in sexual intercourse also rapidly increases with age. And one of the things that concerns me is that when we look at young women versus young men, we see that 59% of females compared with 14% of males did not enjoy the first time they had sexual intercourse. So not only are there these risks for sexual violence and sexual safety, but then we move into the pleasure space and we have to look at, if people are going to be having sex, good sex also has to not only be about safety, it has to be a positive and pleasurable experience for them. And in order to do that, as adolescent health professionals, we have to understand that we have to get into adolescents' heads to do that. So what we see is that there's much national talk. Anytime that we see the conversation moving into the space where it's in teen vogue and young people are talking about it. And we also have to understand that there is a science to sexuality and that there are some truths about love, romance, pleasure, and desire that we have to begin to share with young people as a part of helping them have good sex, safe relationships, unimpaired relationships, relationships that are meaningful for them. So we also have to think about why it is that people have sex. And there are tons of reasons ranging from reproduction to the pleasure experiences that people have, the affirmation that it gives them within their relationships. But then there are also the issues on the other side: exchange for money or goods, exchange for power, compensation for favors or protection. And we have to really think very carefully when we're thinking about adolescents in particular, how those things play out for them. I have spent some time looking specifically at childbearing motivation, and parenting in the future is somewhat or very important to adolescents and emerging adults. And so when we begin to talk with them about how we're going to keep them safe as they engage in sexual relationships, I think we have to also think about how can we preserve their reproductive function and their fertility through those spaces. And there's some real threats to that. I think we have to navigate communicating with them about those threats very carefully, as to not move childbearing motivation to an earlier time. And because what we see is that young people who are ambivalent about childbearing motivation really are at risk for not engaging in sexual behaviors that are protective, like condom use, certainly in our urban environment. And in the United States, there are other risks like sexually transmitted infections that have the potential really to play out significantly in young people's lives. In the United States alone, we have approximately 2.5 million cases in 2018. Our data probably for the last year and a half or so will probably not be very accurate because of the limitations around STI testing. We have no idea where we are going to need to start. But we see that of those that are reportable, that we see that chlamydia dominates. And when we look at chlamydia in particular, we see that adolescents and young adults really are those at risk. So I spent a lot of my reproductive and sexual and reproductive health focused career, focused on first trying to convince other pediatricians in particular and other community professionals who will serve youth that STDs are in our range, and STD prevention and intervention are things that we should work on in order to improve reproductive health outcomes for young people. And you can see here, if you weren't convinced that our age group is the one we have to worry about, you can see the disproportionate impact, certainly on women, in part because of how women seek care, but also in terms of age group. And really that 15 to 24-year-old age group is really within our scope and the work that we're all doing. And although I live and work in a region that is significantly impacted, you can see Maryland here is impacted by sexually transmitted infections. At one point, the state considered it a crisis in every county in Maryland, but I work in Baltimore, which also has a disproportionate crisis compared to the rest of the state. But what we see is that it's a national issue. Anything that is bluish colored on this map, probably even you consider greenish on this map, is facing an issue around sexually transmitted infections. And while you see Maryland we recognize the issues that we have, we're a tiny state. You know, when we look at rates, when you move rates to a big state like Texas or California, you really do have to think about how many people are really impacted. And you can see the diversity of people that are impacted, given, for example, that there's a disproportionate number of African-American folks who live here. There may be disparities here, but the volume of the population of African-Americans that are impacted will be lower. And you'll have to think about what youth from other backgrounds will have, from Latino, from white backgrounds. There are opportunities for us to intervene for all of those young people, and we really have to be concerned. But I have focused a lot on health disparities, in part because there are these factors that reduce the reproductive health potential for women over time. And what we see is that for African-American women compared with white women, there are these factors that reduce their reproductive potential over time considerably. And this is some work done by Michael Liu, who was the former director of the Maternal Child Health Bureau, and Neil Halfon, thinking more about life course theory. And there are all these factors that bear down on the reproductive health outcomes for women. Their socioeconomic status, race and racism, the access to healthcare, and disease status. And so much of my work has really focused on this notion of addressing disease status as something that we can actually change the outcomes for, and we could also prevent it. And so I have focused a lot of my work, probably for the last 15 years, studying a disease called pelvic inflammatory disease, which is what we consider a complex sexually transmitted infection. And it affects around 800,000 women per year in the United States. About 20,000 of those affected are adolescents. It accounts for 300,000 hospitalizations annually, leads to more than 2 million outpatient visits annually, and causes one or more long-term sequelae in a quarter of patients that includes infertility, ectopic pregnancy, and chronic pelvic pain. And I just wanted to remind you that over 80% of urban teens, in particular where I work, say that fertility is somewhat or very important regardless of gender. Now, this is a slide I normally show when I'm interacting with people, but I still feel that, I usually ask, what do you think this is when I'm talking to trainees? But what I will say is, people have a lot of different guesses, but what I would say is that these are sperm, right? And what you see here is a degenerating trichomonad in association with sperm, but you also see bacterial spermia here. It's important because I say, well, how many sperm is in each ejaculate? And so the average sperm count per ejaculate is around 280 million. And their travel time to the female fallopian tube is 5 to 68 minutes. And that makes it clear why the PID risk for an adolescent is 1 in 8 compared with 1 in 80 for a 25-year-old. Now, I started doing this work in part because I experienced a situation with a patient who I had met earlier before her PID diagnosis, She read on the 3rd grade level. She had some behavior issues. Her mom was super concerned about how she was doing. And she presented to our emergency room, and she was discharged from care without enough medication, without good instructions. And she appeared 2 weeks after her PID diagnosis, having not taken any medication or had any interim follow-up, which is completely counter to the national guidelines. And so, people say, well, she's just an outlier. This happened in part because of her cognitive function and her behavior issues. But I said, I don't know that that's true. And so I pulled every chart on every adolescent girl who was billed for pelvic inflammatory disease. And we found that 40% of patients were prescribed inadequate therapy. And I got a lot of pushback from some of my AD colleagues, a lot of pushback in sort of a national discussion. But the reality is that this data actually suggests that we were doing great at Hopkins, right? And so I worked with colleagues who really looked at national provider adherence to the CDC guidelines and United States emergency departments around pelvic inflammatory disease care, and really found that only 30% of patients receive care according to national standards, looking at a national data set, and about 70% were non-adherent, right? And what we also found was that if there was no subspecialty consultation, adolescent medicine, OBGYN, they were 5 times less likely to adhere, that adolescents fared the worst, 76% versus 68% for non-adherence, adolescents versus adults. And that medication regimens were just really problematic. So for a disease characterized by infection and pain, 38% of women received no antibiotics or pain management. And so when I put it all together, that means all the data together, it looks like of the 200,000 adolescents per year in the United States that are diagnosed with pelvic inflammatory disease, only 60,000 of them receive care per the CDC guidelines. And that is a problem. That means we're not protecting their reproductive fertility. So I decided to intervene locally first. So I developed an institutional intervention to really improve the quality of care for adolescents treated in pediatric ambulatory settings for pelvic inflammatory disease with my colleagues, both in adolescent medicine and pediatrics, but also in the emergency department. I think it was something we all wanted to do together to change things. We created an algorithm, clinical practice guideline. We gave everybody medications. At that time, I could give every girl who came to the emergency department a full course of doxycycline to take home with her for $300 a year, everyone. It was $3 per person, and we had around 100 girls per year diagnosed with mild to moderate PID, and we were able to treat them all. And we provided them with standardized discharge instructions so that when that patient who leaves in the middle of the night at 2 o'clock in the morning, they wake up and they know what they're supposed to do. And if they don't know, they can read what they're supposed to do, and they have instructions on where to call if they have questions. And what we found is that with the protocol, patients were 8.5 times more likely to receive care according to CDC standards. And so the question for me was really, does outpatient treatment work for adolescents? Total backstory as part of my own training. I'm aging myself, that as a resident, we admitted everybody to the hospital. As a fellow, we admitted everybody to the hospital. So now as a new attending in this place, they're just discharging people to home so that they can deliver care. And some of that is reinforced by work done by colleagues in Pittsburgh that really, as part of a national randomized controlled trial to try to look at the difference between inpatient and outpatient therapy. And what we saw was in their study was that inpatient therapy and outpatient therapy had really similar outcomes. It's important to remember that people are only hospitalized for 3 or 4 days. So they still did most of their treatment in the outpatient setting. That's just something to remember. But another colleague, Smith et al., really demonstrated using that data that it was never cost effective to treat anyone, adolescent or adult, in the hospital for a few days for mild to moderate PID. And that changed the CDC guidelines. So for over a decade now, we've been operating on a low intervention level for PID, including for adolescents. And the challenge is that adolescents and young adults are still managing their care alone. their medication adherence is low, their risk reduction needs are high, their 72-hour follow-up is low, their risk for recurrent disease is high, and their future fertility is at risk. I also think that people misinterpreted the PID evaluation and clinical health study findings. While it's true that there are a number of women who became pregnant over the course of the study, which went on for multiple cycles, and it is true that they had very similar outcomes in both groups. But the reality is that 21% of women had recurrent PID, 19% of them had infertility, and 43% of women had chronic pelvic pain. And this poses a challenge because we did some additional research to look at those three things in particular, in terms of we did some work with young people and parents, and those outcomes are completely unacceptable to patients. We also demonstrated that using the PEACH trial data, we collaborated them to look at adolescent girls less than 19 years of age, less than or equal to 19 years of age, to see what their outcomes looked like. And the reality is we found that if they had recurrent PID during the study, they were 5 times more likely to have chronic pelvic pain. And, people will say, why is this 72-hour visit important? We're just discharging them to home. They have their medications. Why do we care? Well, 70% of patients, certainly at Hopkins, are seen in the pediatric or adult emergency department for diagnosis of PID. We see a very small percentage of those in adolescent and young adult medicine, but the young people are there. And so what we see is that there's a lot of work that still needs to be done with these patients, including us reassessing to make sure that their pain is resolving, that they are feeling better. But they have this, but half of them have a history of STD, half of them have already had a history of pregnancy, and only 20% of them are using any kind of contraception, including condoms at last intercourse, which means that that 72-hour visit is critically important for risk reduction for both sexually transmitted infections and HIV and pregnancy. And we have an opportunity to provide them not only with resources, but also the important counseling that they need. So I decided to develop a strategic approach to management around pelvic inflammatory disease as a part of my career development process. And really, I decided that what was needed was, the PEACH trial, for example, is very expensive, even though it's this mixed inpatient outpatient model. And outpatient treatment is super cheap, but very ineffective. And so I felt that we needed something that was more expensive than a current outpatient treatment approach where we're not following anybody, people aren't coming for care, people aren't taking their medicines, but certainly less expensive than a large randomized controlled trial like the PEACH trial, that we needed something to do something different. And so I thought that, one of the proven methods for adolescent health service delivery has been the use of community health nursing as a strategy. And I submitted it to the NIH, and they thought they didn't think it was innovative enough. So I added a technology component at that time, which was pretty innovative, in order to bolster the work of the community health nurses as a part of the trial design. And they thought that was a great idea. And so the technology enhanced community health nursing study was born. And as a part of this study, we used the integrative model of behavior to really try to transform attitudes and beliefs, optimize self-management, remove environmental constraints to improve PID care amongst young people. The key components were we had provided SMS reminders for medication administration by themselves, appointments, and provided adherence support. And a community health nursing visit occurred to replace the 72-hour CDC visit at 3 to 5 days. And we, as a part, for an STI prevention program. And as a part of this CDC-approved STI prevention program, we used the sister-to-sister teen intervention, which was demonstrated to reduce STI HIV risk behaviors, particularly in African-American girls, which were the majority of our population based on our prior studies. And his tagline, which I love, is respect yourself, protect yourself, because you are worth it. And what we found was that, first of all, we were able to actually complete the 72-hour follow-up so much differently by sending the community health nurses out to the field and by using this and just being in the intervention group, and you are 86 times more likely to receive that follow-up visit according to the CDC national standards. We also saw that STI positivity changed specific to gonorrhea and chlamydia over time. There was a significant decline in the intervention group compared with those who really expected to follow the standard of care, which is to take care of it all yourself, even in a supported environment like our study. I think one of our challenges is that there are some other STIs that are not reportable or that may be new, like Trichomonas vaginalis and Mycoplasma genitalium, which I chose a really long time ago to include in our study. And what we found is that they didn't decline for Trichomonas and Mycoplasma. So even though it is interesting because the CDC guidelines around PID treatment don't really consider these. So metronidazole is really considered optional for treatment in the CDC guidelines, but would have covered Trichomonas vaginalis, and Mycoplasma genitalium had no recommendations at that time. It wasn't even in the CDC guidelines when we started this study. And what we see is that doxycycline, for example, which was originally one of the first line treatments, has about a 50% resistance rate, so ineffectiveness rate. And so people are not really able to respond to treatment. And so the CDC guidelines, the 2015 guidelines changed and mycoplasma was added, but there were no screening recommendations and there was no commercial testing available. So it's like, this is out there, but there's nothing you can do about it. And Trichomonas vaginalis is an old STD. And again, antibiotic coverage is optional, and it can be harsh when taking doxycycline as well. Now, it's interesting because I wanted to also think about this from a non-PID sample, just to see whether or not this is even a problem in the community. And this is some preliminary data we published from a child. This has about 483 of the about almost 900 women that we have data on. But we published the findings early because they were so significant. You know, we really saw that 16% of this sample of women from 13 to 29 years of age who were seen for routine care in pediatric, adolescent, and OBGYN clinics at Hopkins really demonstrated to have 16% had mycoplasma, 9% had Trichomonas vaginalis, and 8% had chlamydia, and 1% had gonorrhea. So we spend a lot of effort tracking down and treating chlamydia and gonorrhea, but there are these other STDs that it suggests that they're on the horizon. I think the biggest issue is that we didn't actually see that many differences between pregnant and non-pregnant women, which suggests that there is going to be a real challenge in terms of our ability to think carefully about the impacts on pregnant women from a maternal fetal health perspective. People also say a lot about trichomonas and that it just is a pathogen just living in someone's body, and that there's nothing that we should be done about it, which is sort of the rationale behind this notion that it doesn't need to be reportable to the health departments, and that we don't need to keep track of it, even though it's been associated with acquisition of STIs, including HIV, and really can be associated with adverse outcomes from a maternal child health perspective for pregnant women. But I would argue, right, that I don't believe this argument that people would care, because we get so excited, as an example, as clinicians when we go into the lab. And I would argue that if you showed your patient that this is what was happening on her wet prep, that she would not be happy or okay with the notion that we weren't treating her, right? Or that we weren't screening for it on a regular basis. I think when we do see this, we treat people, but that we're not screening for it. I think it would change how people think about this disease. And we also have to innovate when we think about Mycoplasma genitalium. What we see is we've looked at 84 of our samples early in our work, and there were 13 positives based on our GenProbe results. And we did microlive resistance testing on these samples and found that, the sensitivity was 92% and specificity was 99%, but 50% of positives had mutations for the 23S mutations, which means they were going to be resistant to macrolides. And that's really important when we think about adding other drugs like azithromycin to 4. So the dilemma is that there are no public health control programs in the United States for Mycoplasma and Trichomonas. Recurrent and persistent infection with Mycoplasma and Trich is associated with ongoing inflammation in the female genital tract, microbial shifts in compositional biology that hinder the growth of healthy bacteria, and there's an increased risk for secondary STIs and HIV. There were no interventions designed to address vaginal health using precision care. And I just wanted to point this out to you that I think people talk a lot, for example, about gut health and try to help people understand that there are healthy bacteria in the gut, where there's the same concept should apply to the vagina as well. So you can see here that there is a bacteria called Lactobacillus crispatus, and it is predominantly a lactic acid metabolite profile. But then what we see in patients, certainly who have BV or who have community state property 4, where they have other bacteria, much more polymicrobial infections, you see over time that they more predominate with short chain fatty acids. And what happens is that increases their risk for STIs. And what's interesting to me as well is you can see that the gut health people have dominated. There are all these studies all over the world, and yet only less than 3% of them are focused on the female vagina. And so there's a ton of work to be done there. And so what's next? So for me, I submitted a renewal application of our TechN study, and we decided based on our results around Trichomonas and Mycoplasma that we wanted to do a precision nursing study. And that while our initial study followed the CDC guidelines and their approach to care, meaning you inform people of your results, they can come back for follow-up care if they're positive, you can treat intervening infections. But it was really a lot self-done. I mean, that was the whole point of the CDC shift in care, is that people had to do this all in the outpatient setting on their own. But we decided that in our intervention, we were going to put everybody in the intervention because our intervention works. And we were going to see if we added this additional layer of advanced practice nursing to it, whether or not we would actually be able to optimize care, treat people in the field, treat their partners in the field, really do the hard work of making sure people clear these infections. That's what we wanted to do. And it's important because we also thought about people in the context of their relationships. And this study was different than the other study because we also found that people, particularly those who are going to be, who are more likely to be STI negative, actually maintain their relationship at 3 months, were more likely to maintain their relationship at 3 months. We also developed another study, which was called the Experience study. We have since changed the name to the Sexperience study to help clarify on social media and other places how it worked. But we found that people couldn't communicate about their STD. And initially, we were trying to recruit people when they actually actively had their sexually transmitted infection, but found that was a hard time to recruit people for the study where they're going to talk about it, even though that's the time they needed to talk about it because they were too angry. And so what we found is that recruiting people, mostly late adolescents and young adults, tended to be the most receptive to it, that we're actually able to, the preliminary data suggests that we're able to help them enhance their communication and to think more actively about prevention of STIs in their relationship by use of our intervention. We also have been working on using the tech intervention strategy with youth who have HIV and to try to improve their adherence to care. And so this is a study that I am MPI with Dr. Allison Oglewood Hopkins, and we are at multiple sites, including DC Children's, as well as the University of Florida and in Jacksonville, and really trying to think about ways that we can optimize care for young people living with HIV, particularly to improve their adherence and to get them to zero. I also have a global aspect to the work that I'm doing, especially if you look at STIs and HIV. You can see that while there are people certainly living in North America with HIV, that places like Sub-Saharan Africa really predominate. in terms of the number of people impacted and their risk. Even if you look at other parts of the world, it's a real challenge. And so the other thing is in the United States, we're really very focused on, appropriately so, on young men who have sex with men because of their risk for HIV acquisition and adverse outcomes. But it's really important for me to think about globally because about 50% of people who are impacted by HIV/AIDS worldwide are women. And what's interesting is if we go back to this whole notion of having good sex, that 88% of HIV positive patients reported that they have reduced enjoyment of sex. Probably in fact, because we have not managed the HIV effectively and they worry about their partners. And the impact of STIs have significant impact on sexual experience in general, not just HIV. When you look at HPV and herpes, you see that that applies as well. Sexual anxiety, sexual depression is up. They have decreased sexual optimism, decreased sexual satisfaction, and decreased sexual self-esteem. And while some of that can be mitigated by disclosure and an understanding partner, I think oftentimes people are very uncomfortable with these disclosures. And so some of our work is now occurring. This is a project in which I'm a co-investigator on with a team from the University of Minnesota and a team from a university in Dar es Salaam, Tanzania. And we have a collaborative effort to begin to address sexual health in clinical practice by training medical students, nurses, and midwifery students to do sexual health counseling in practice as a part of their curriculum. And it has been demonstrated in our pilot work that we did several years ago. We really demonstrated our ability to really integrate this sexual health curriculum that was based originally on the PAHO curriculum that we revised for the African context, and that it appeared to preliminarily be effective. We are now evaluating it in a randomized controlled trial. And what I love is that we also have been able to integrate some aspects of work that we do in the United States in our own training at Hopkins, which is use of simulation to really allow people not just to have didactic education, but to really practice what they've been doing and to have an opportunity for self-critique. And here you just see one of our videos from our pilot. We piloted the simulation to make sure that we had everything in place. It's interesting because we had planned to use an innovative technology for real-time communication, but due to the COVID-19 pandemic, switched to also Zoom for this, which actually turned out to be an amazing strategy for us to not only see both the people at the same time, to see the interview, to rate the interview, but really to continue to deliver this educational intervention to young professionals in training. We also have been working very hard on other areas of sexual and reproductive health, including family planning. So about a decade ago, partnered with Kathy Tomaszewski, our clinic nurse, as well as Ann Burke, who runs the Family Planning Fellowship Program at Johns Hopkins, to develop a LARC program in our space in a primary care clinic. And we actually have found that women do very well with both the IUD placement as well as Nexplanon, that we have similar outcomes. We also have worked very hard to make sure that we train a diverse group of people in order to do this work. And so this is our training team in the pediatric and adolescent medicine setting. And what we really see is, here's Rachel Linsky, who's one of our former fellows, now faculty member, really working hard to make sure that we train the next generation to do this work in the context of adolescent healthcare. So what's exciting about our work is that it captures the innovation of person-based communication using technology and community health nursing. It incorporates new STI diagnostics to improve the precision of diagnosis. We're using transformational motivation with couples as an untapped resource for precision care and to improve the relationship experience for young dyads. We've identified a potential opportunity to address vaginal health in women facing STI disparities. We're adapting our TechIn study to improve adherence to antiretroviral therapy for youth who are living with HIV. We are creating opportunities for prevention of STIs and unplanned pregnancy, and we've expanded our work on sexual health research into the global arena. I think the question that remains for us is sexual freedom for women in high STI prevalent communities really attainable? And what can we do to promote a healthy sexuality? And so the first thing is we have to promote condom use. For many people, it's fallen by the wayside, but the data actually show that consistent condom use increases the colonization of that bacterial type that I shared with you, that is considered protective in the vagina. And so we have to continue to integrate work that has been proven to work for increasing self-protective behaviors as it relates to sexually transmitted infection into our work. And I consistently use this one because it really works well with urban young women. I think we have to change how we think about condoms. This is data from the National Survey on Sexual Health and Behavior and was shared with me by Michael Reese, who was the head of the work at that time, and really demonstrating, this is from 2018, really demonstrates that young people really do have sexual satisfaction. This is the female perspective, but the male perspective is even higher, that they're able to reach orgasm and their partners able to reach orgasm. And so largely when people say that they are not having some positive experience in their sexual relationships, it's really not reflective of what's happening nationally. I think we have to follow the CDC treatment guidelines. I sat at the guidelines meeting for this last group over a year ago. And the reality is really people spend a lot of time pulling together evidence for clinicians, and for us to ignore it, it's just not acceptable. I think that's where I started my work. And I hope that now we realize the importance of actually really investing quite heavily and making sure that people get the care they need. We have to think more carefully about the national sexuality standards. They have been available since 2012, but we do not yet have nationwide implementation across the country to do that work. And they've since been revised. And so we now have an updated curricula that will potentially change things if we could find an effective way to integrate it. We have to remember that vaccines are not just for babies. I think many of us feel very comfortable with HPV as a vaccine, but it's important for us to really think about how we deliver that messaging to patients and families. You know, I think we think nothing, you know, it has a similar adjuvant to the hepatitis B vaccine. And it's interesting. No one looks at their infant at day of life 1 or 2 and says, you know, I'm worried that this beautiful baby is going to have sex with an IV drug using person, or that they are going to have sex with somebody who risks, who may have HPV hepatitis B at the time. Yet at the same time, day of life 2, before we leave that hospital, everybody's getting an injection. And so I think that we have to really, because we want the best for our infant, and we're not thinking that something bad is going to happen. And I really think we have to think that way about adolescent vaccines as well. They're not always going to be with us. They're at a period where they're at more likelihood of being exposed to something. Why not keep them safe? I think we have to understand the impact of politics on people. These are some old images that were associated when we were having the Title X fight in the United States, which I think is hopefully almost over. But it really does transform care. You know, we were one of the Title X sites that were going to lose their funding in the United States, you know, and Baltimore of all places where we probably needed the most. I think the state was prepared to make sure that we could maintain family planning services, as an example, in the state, no matter what happened. But I think that it was a real risk. And so we have to become more powerful on behalf of young people. And for me, that means that it may mean testifying at the local school board. It may be going to a congressional briefing to talk about something else related to that. It may be standing up here. I am testifying about Title X and why we need to have Title X in place. But we also need to write op-ed pieces. So there are tons of ways, in addition to delivering care, working with youth one-on-one, in which we can change their outcomes. We also have to think more broadly. This focus was primarily focused on cisgender women, in part because that's been my area of work for many, many years. But I also want to say that there are huge disparities as it is associated with delivery of sexual and reproductive health services to sexual and gender minority youth, and that we have to be prepared in practice to make sure that we care for them very thoughtfully, because the adversity associated with not doing so is so high. We have to also think about our biomedical models and the benefits versus risks and side effects. What happens, young people may go on PrEP and reduce their risk for HIV, but if they stop using condoms, they still are at risk for gonorrhea and chlamydia and other sexually transmitted infections. And so there are ways that we have to really think about biomedical interventions versus behavioral interventions. We still have to think about adolescent behavior. We also have to think about how we talk about things. While it's true, long-acting reversible contraception is certainly the most effective in terms of making sure that people can have highly effective contraception with very little effort, but not everybody wants that. Not everybody wants to have a procedure, is concerned about having something in their uterus. And from a reproductive justice perspective, while we can give people the ease rates and the low rates of pregnancy, some people are willing to do hard work in order to control their contraceptive practices day to day. And so we have to think that we can't poo-poo any method of contraception. We can offer tell them what's most effective from a low utilization perspective, but we have to give them all of the options, and so that they can make good decisions that work for them. We have to meet young people where they are. So we are meeting young people in our studies on Instagram. We're meeting them on Facebook if they're there. Instagram is sort of the Facebook's young people's version. We've talked a lot about trying to develop a TikTok so that we can recruit young people to some of our work designed to help them. But that's where they are, and that's where we have to meet them. We also have to think more thoughtfully about having multiplex point of care testing, so that there are ways for us to think thoughtfully about giving people their results right away and intervene in real time. In our clinic, we still have a lab where we can do everything from wet preps to gram stains. We can do it all. Pregnancy tests, we can do it all. But I think that if we could find better testing for all of these things, then we could give people results right away and treat them right away. I think we have to partner with nonprofits and to start young. I love the work that Advocates for Youth has done around reaching the tween age group, 11 to 14-year-olds, to provide high quality, developmentally appropriate sexual health education that has been very useful. It's now being used around the world. But we also have to discard fear as our strategy in communicating with young people around sexual health. And I love this work that the folks in Australia have done in their development of these two characters, Condom Man and Lubalicious, in terms of thinking about it, because what they see is that people can have this super positive, pleasurable experience if they take care of themselves. I think finally, we really also have to embrace empowerment, and that is critically important for the work that we are going to be doing around sexual health. And that includes sometimes stepping out into that space to really remind people as health professionals and other youth serving professionals where they can get care and the importance of seeking care. I'm gonna hopefully have you all see this video today, just so that you have an opportunity to see an example of some of that work. I show you this because I showed it once at a training curricula, and that I was delivering as a part of a summer program. And I remember having young people come up to me afterwards and who were from out of town, asking me if there was any place they could get tested for sexually transmitted infections after their talk. And these are all sort of graduate students and people interested in public health and medicine. So it might've been a group you might not have thought to just come up that way, but it was really powerful that they felt safe and comfortable doing so in that space. And after that airs, I'd be happy to answer any questions and to have conversation with you all. So thank you all for inviting me to talk this morning. I hope it's been a good conversation, and I look forward to continuing to discuss this with you. Thanks again.